Okay, this is chapter 16, intrapartum fetal monitoring. We talked about antepartum fetal monitoring before. This is intrapartum fetal monitoring. When we look at intrapartum fetal monitoring, we're basically talking about monitoring of the fetal heart rate. And there are many different ways of doing this. The most common methods historically have been intermittent auscultation, where you use a stethoscope, listen to the heartbeat, you count for 15 seconds, multiply by 4, and you have the heart rate per minute. More recently, we've had external continuous electronic fetal monitoring and continuous internal electronic fetal monitoring. And we're going to look at each of these. The question I have for you is, which of these methods has the best outcome? And the answer is, they are all equivalent. There is absolutely no evidence that electronic fetal monitoring gives you a better outcome than intermittent auscultation, but we have got to where in our society, in America, the standard of practice is electronic fetal monitoring. And if you don't do it, then you're holding yourself out for liability action. And yet there is no good evidence that one is any better than the other. Here's a papa who is trying to hear the fetal heart rate. This is very difficult to hear because the fetal heart tones are a very low frequency, hard to hear. You've got to have a bell, like this wooden fetoscope that I got from Amsterdam. Here is a metal one. You can see this is a little bit younger obstetrician. This is the DeLee stethoscope, or fetoscope, which was developed by Dr. Joseph Bolivar DeLee. We use this for many years. You hold it with your forehead. The disadvantage is a mother can't hear the fetal heart. And that's a method of bonding, is for her to hear her baby's heartbeat. This is the Hahn fetal monitor. Edward Hahn was a graduate of Loma Linda University School of Medicine. He went to Yale University and developed this fetal monitor that cost at that time $10,000. This was in the late 60s, early 70s. You know what you could buy for $10,000? You could buy a house for $10,000. Why did Dr. Hahn go through all of the effort to construct this fetal monitor? The reason is, it was felt at that time that the cerebral palsy had its onset during labor. And if only we could identify the fetus that was in trouble early and deliver that baby, we could eliminate cerebral palsy. What do you think? It's a great goal. He had good goals. Did it work? This was an article from the New England Journal of Medicine, 2003. Can we prevent cerebral palsy? And the summary of the article was, at this point, little evidence that we can. And when you look at the data, the time when cerebral palsy originates in most cases is not in labor at all. It is antepartum. Only 4% of cerebral palsy is due to intrapartum events alone. In red, you can see cerebral palsy in developing countries over the last 30 years. It really hasn't changed significantly. What has happened to the cesarean rate, however? What we've done with our fetal monitoring has increased the cesarean rate, but really hasn't done a whole lot to change the cerebral palsy rate at all. Electronic fetal monitoring does not identify the preterm neonates who develop cerebral white matter injury, and the evidence would suggest if it's going to happen, it's probably already happened, and the fetal monitoring just finds out the baby that's going to do poorly, but doing an emergency cesarean probably does not change the outcome. However, you're going to need to know this for the exam, so let's go through this. The external sono device, which is for picking up the heart rate before labor, we've already talked about. This is a Doppler device that sends a signal, and the signal reflecting back is at different velocities depending on the speed of wherever it is hitting. And if it's moving heart, which is reflecting the sound back, we're going to pick that up. We already talked about the external Toco device, which picks up the uterine contractions. And here's the patient with the external devices on. The advantage is the cervix does not need to be dilated, the membranes don't need to be ruptured, and you can do this before labor. The disadvantage is it's not quite as accurate. If you have a 400-pound mama, you're not going to pick up the contractions as well as if she is 100 pounds. And the same thing with the fetal heart rate. For that reason, we will often use an internal scalp electrode. This is my thumb and my fingers. This is the tip of the scalp electrode. This wire, which is on the end, this needle, is about the size of a 28-gauge needle. Very, very tiny, smaller than an insulin syringe. We don't screw this into the baby's head. We attach it gently to the superficial layers of the scalp. Here we see the maternal QRS complexes, which are the large signals, and between them are the smaller fetal QRS complexes. Let me show you this a little bit better. You can see the big maternal ones. Look at the fetal ones. Here's one. This one is hidden. This one is hidden. You can barely see this one here. This one is hidden. Here's a fetal QRS. Here's a fetal QRS. Can you see these here? Okay. What the fetal monitor does, it measures the interval between the QRS complexes, and using a reciprocal function, it then comes up with an instantaneous fetal heart rate per minute. The fetal monitor does only one thing, and that's calculate the instantaneous fetal heart rate. That's all it does. It does it very well, but that's about all it does. Now, does it help the outcome? Here we have the scalp electrode, which is on the fetal head, and it picks up the QRS complex. We subtract the maternal QRS, and now we have the instantaneous fetal heart rate tracing. We can measure the strength of the contractions using an internal uterine pressure catheter. And here you can see the catheter goes down through the cervix into the uterus. And the whole idea here is it measures the hydrostatic pressure. The hydrostatic pressure should be equal throughout. Then the paper, which comes out the machine, has on the top the fetal heart rate, and here we have the contractions. And here's a patient in labor. I happen to know her quite well. Right here in this uterus is my son. This is my wife in 1976 in labor. And that's the end of fetal heart rate monitoring. Let's look at evaluation of fetal monitor tracings. What is the likely fetal outcome with a reassuring electronic fetal monitor tracing? A normally oxygenated, healthy baby. What is the fetal heart rate with a non-reassuring electronic fetal monitor tracing? A healthy or a sick baby? Most likely, it is a normally oxygenated fetus. There is a 99% false positive rate when we say that the baby's in trouble. Most of the time, the baby is okay. The electronic fetal monitor is a very good indicator of good fetal status, but it is not a very good indicator of poor fetal status. Let's look at our sequential steps in evaluating our tracing. The first thing we want to look at is baseline fetal heart rate. I think it's important to have in your mind a sequence that you always follow. First, we want to look at what the fetal heart rate normally is, which is 110 to 160. If it is faster, we call that tachycardia over 160. If it's less than that, it is bradycardia. The question is, are babies who are tachycardic in trouble? And the answer is not always. Are babies who have bradycardia in trouble? Not necessarily. So an abnormal fetal heart rate does not mean a sick baby. Baseline changes to fetal heart rate. This is what you'd expect with a normal fetal heart rate tracing, 110 to 160. This would be tachycardia, and you can see there's good variability of this tracing. And here we have bradycardia. And the important take-home is babies who have heart rates outside of the normal range are not necessarily in trouble. This is a great board question. You need to know this. What maternal medications can cause fetal bradycardia? Beta blockers are going to slow the heart rate of the mother and of the fetus. Local anesthetics, such as with a paracervical block, we just talked about this, can lower the heart rate. Fetal tachycardia can occur with beta agonists, such as ritodrine terbutaline, and atropine-like medications, parasympatholytics. Decreased variability of the heart rate can occur with betamethasone and corticosteroids. How about if the mother has systemic lupus erythematosus and she has anti-Rho, anti-La antibodies? This baby could have a complete heart block. And here is a fetal heart rate of 60s. Is this baby in trouble? No. It increases its stroke volume so it can maintain the cardiac output. It's important to remember that changes in fetal heart rate are not necessarily associated with poor fetal outcome. All right, we've talked about baseline fetal heart rate. Now we want to look at periodic changes. Periodic changes are changes in the fetal heart rate which are temporary, which are not changes in baseline, and will usually last no more than 1 to 2 minutes. We talked about accelerations in response to the NST, and those are always reassuring. And there are 3 kinds of decelerations. There is the early decelerations, the variable decelerations, and the late decelerations. Here are accelerations, and we've already looked at that. This is a rise in the fetal heart rate of 15 beats a minute or more, lasting 15 seconds or more, and they are a response to fetal movements. These are always reassuring. This is from sympathetic stimulation, and we're always happy to see accelerations. Decelerations, there are 3 of those we talked about. There are early decelerations, and this is a response to head compression of the fetus. The management is basically, don't worry. These have no impact on the outcome. You can ignore them. They are seen more commonly after the membranes have been ruptured. Variable decelerations are a response to cord compression, the umbilical cord compression. These, if they are severe, are troublesome. And a severe variable deceleration is one that lasts 60 seconds or more, drops 60 beats a minute or more. Otherwise, they are not to be worried. Late decelerations are a response to placental insufficiency. And these are always troublesome, even if they are mild late decelerations. Let's look at the characteristics of these. In your notes, you have this tracing: early decelerations, variable decelerations, and late decelerations. The mechanism of fetal heart rate early decelerations, we already said, is head compression. This is vagal stimulation, which slows the heart rate. Here we have a tracing. You can see contractions, and notice the early decelerations. The characteristic is that as the contraction begins, the deceleration begins. At the peak of the contraction, we have the lowest point in the deceleration, and then we have a gradual return. Notice that the contractions and the decelerations are simultaneous. They are superimposed on each other. Gradual drop, gradual return, a mirror image of the contraction. Variable decelerations are also mediated by the vagal nerve and are due to umbilical cord compression. Look at the difference in the appearance of variable decelerations and early decelerations. With variable decelerations, we have a sudden drop, a sudden return. I call this a box-like shape. Sudden drop, sudden return. Okay, the blue bars are the contractions, and here are the decelerations. Is there any systematic relationship between the deceleration and the contraction? No, they are variable. And notice they are sudden drops and sudden returns. Now this might be a severe. It drops 60 beats a minute. But this one here is what we call a carrot. of no clinical significance. Late decelerations are mediated through uteroplacental insufficiency, and these are always worrisome. Here we have the contraction, and here we have the deceleration. I want you to notice the baseline heart rate is about 170 to 180, so we have a tachycardia. Let me superimpose on here the decelerations. And what you see is the peak of the contraction and the lowest point of the deceleration are not synchronous. The deceleration is always late in relationship to the contraction. And that's true over here, where we have the peak of the contraction and the lowest point of the deceleration. You notice that the end of the deceleration is after the end of the contraction. So we have early, variable, late deceleration. So we've looked at baseline heart rate, periodic changes, and now we look at variability changes. This is a normal variability. These are the rapid rises and falls of the heart rate, which is a reflection of the interplay between the parasympathetic and sympathetic nervous system. This is healthy. Let me show you a troublesome fetal heart rate, and the variability is basically gone. It looks like you've got a ruler and you're drawing a straight line. This is not reassuring. Look at this tracing here. This is flat as a pancake. I don't like it. Look at this tracing here. Flat as a pancake. Let me draw a line across here, and you can see it is so flat. Decreased variability, not a good sign. The mechanism, we said, is the interplay between the sympathetic and parasympathetic. The sympathetic rises, the parasympathetic lowers the heart rate. Okay, so we've looked at baseline heart rate, we've looked at periodic changes, we've looked at variability. Now let's look at reassuring versus non-reassuring. The criteria you need to know. If you have a baseline heart rate, which is 110 to 160, accelerations are present, there are no decelerations of any kind, variability is good, you can be almost sure you got a great baby here, 99.9%. Notice we use the term reassuring. One of the concerns about using the term fetal distress when we describe a non-reassuring fetal monitor tracing is it is not precise. This is American College of Obstetrics and Gynecology Committee opinion. And what they say is the term fetal distress is imprecise and nonspecific. And most of the time when we have a, quote, fetal distress pattern, the baby comes out screaming. Was it truly fetal distress? It was doctor distress. So rather than use the term fetal distress, we use the term non-reassuring fetal status and then describe what you see. So when we have a non-reassuring pattern, it may represent a baseline tachycardia, baseline bradycardia, it may be severe variable decelerations, late decelerations, absent variability, but this does not mean that the baby's in distress necessarily. But it is concerning. It is non-reassuring. What do we do about a non-reassuring fetal monitor tracing? Here we talk about intrauterine resuscitation. Intrauterine resuscitation is generic measures that are designed to enhance oxygen transport from the placenta and the mother to the fetus. Firstly, we want to decrease uterine contractions because the intravillous space is being compressed with contractions, and that's going to decrease the amount of blood flow. So if there is oxytocin going, discontinue the oxytocin. If she is having contractions but no oxytocin, give some terbutaline. See if we can space out the contractions. She may have an intravascular fluid deficit. Let's give a bolus of 500 milliliters of Ringer's lactate. normal saline. See if we can enhance the intravascular volume. Give high flow oxygen by face mask, 8 to 10 liters. See if we can increase the inspired oxygen concentration that the mother is breathing in. Change the position of the mom. If she's laying on her back, she may have inferior vena cava compression. Put her on her left side. If she's on her right side, maybe there's umbilical cord being compressed. Change position. Do a vaginal exam to rule out a prolapsed cord. This is particularly if you see variable decelerations or bradycardia. And the last thing is do a scalp stimulation. Scalp stimulation is very similar to the vibroacoustic stimulation. If you have a healthy baby, you will see accelerations. And the way you do scalp stimulation is to take your finger and just stimulate the scalp like this. Here we see a non-reassuring fetal monitor tracing. Many of these severe decelerations. What's going on? Notice the frequency of the contractions. They're coming every minute. This is uterine hyperstimulation because of excessive oxytocin. Shut off the oxytocin, what happens? This looks like a great tracing. Interventions which normalize the fetal heart rate. Certainly makes good sense. That's the end of intrauterine resuscitation. Now we move to fetal pH assessment. The normal fetal scalp pH is over 7.2. In the olden days, we used to do a lot of fetal blood capillary pHs. On the west coast of the United States, it's not done very much anymore. East Coast, New York, perhaps a little bit more, and you need to know how to do this. This is done in labor if you have a non-reassuring or at least a ambiguous fetal monitor tracing. If you have a clearly ugly-looking tracing, you just can do the cesarean. But if you're not sure, you can do a fetal blood capillary pH. The membranes must be ruptured, the cervix must be dilated, the station must be low enough so you can put this device against the fetal head. There is this hollow cone-like device. We place it against the fetal head and we want to hold it firmly to prevent any amniotic fluid from getting in and contaminating. We have this device which has a blade on the end, and we put this inside the cone and we create a nick on the scalp of the fetus. And the whole idea is that we will get free-flowing capillary blood which we can then put into our heparinized tube and send to the laboratory for pH determination. What was interesting was that when they pushed against the fetal head with this cone, and if there was an acceleration of the fetal heart rate, the pH was always great. Scalp stimulation, acceleration, good. Maybe we don't need to do the fetal blood if we can get a scalp stimulation acceleration. So they did a study by taking an Alice clamp. This is an Alice clamp. It's got serrations on the end. And here I am picking up my own skin, clamping it. It's a measured stimulus. You go to 2 clicks. And the study was done by doing a scalp pH and a scalp stimulation with an Alice clamp. And what they found was every time the pH was normal, there was an acceleration with the scalp stimulation. And so one way that you can avoid or at least decrease doing scalp pHs is by doing the scalp stimulation. If the pH is over 7.2, reassuring, allow labor to continue. If it is less than 7.2, we say none reassuring, and at that point, we really probably need to do an emergency cesarean. Most of the time, the baby comes out fine, but since we don't have any better way of reassuring ourselves, we do the cesarean. After delivery, I like to take some of the umbilical cord segment, doubly clamp it, and then aspirate fetal blood to see what actually was happening with the baby. Are we going to take arterial or venous, which is the best reflector of fetal status? And the answer is it's arterial. So we take arterial blood, and this is often helpful to identify Was the baby in trouble or not? And that is the end of pH assessment of the fetus.